I'm Dr. Dishinger. Thank you all for coming out. I was looking at the picture that Holland Hospital put here, and it's so pretty to see the blue skies and the green grass. And I was thinking, man, wouldn't it be nice if it was that sunny out? And then I thought, you know, at least it's not snowing, right? Isn't that the Michigan mentality? At least it's not snowing. So thank you all for making it. Nobody had to ice skate in, so that's good. You know, I'm just going to slowly get started here. I think most everybody's here. We have a packed house, and again, I appreciate that. We're here to talk about varicose veins. We want to understand the process of varicose veins, how they develop, and then some of the treatment options. You know, at the beginning of every talk, I feel it important to sort of report that I don't receive any financial support or incentives from the company that I'm going to talk about tonight. I simply talk about the company because I feel their product is good and it's good for patients. So I did want to, you know, thank Holland Hospital, Lakeshore Health Partners, and the two ladies in the back for being here. Brittany and Lori are sitting behind you, and they're both they both work with me in the vein clinic. So they'll be here tonight to answer some questions at the end and help folks sign up for vein screening if that's something you want to do. So anyway, I just wanted to move along to what we're going to talk about. So there's a lot to go through. We got a busy agenda. First and foremost, we're going to talk a little bit about the prevalence or how common varicose veins are. We're going to move into risk factors, talk about symptoms. That's really, I think, why a lot of folks are here tonight, is because you're having symptoms. We're going to talk about how we develop varicose veins, some of the ways we diagnose the various conditions, and then lastly, we're going to review the treatment options. I do have a short video as well to go over, so that'll be a nice thing to kind of wrap it all up. So I like analogies. People who know me or come to see me in the office will often get me speaking in analogies. I always tell patients when I see them to talk about varicose veins, to think of the veins in your legs like the web of a spider. There's a lot of connections in this web. One layer connects to another, and the key is that they're all different. Everybody's different. There's interconnections, different depths, and some of the layers obviously are more important than others. So there's my analogy, my spider's web. So let's keep going. I like to ask a few true and false questions just to kind of get the audience involved. This is the first one. Varicose veins are the same as spider veins. False. Very good. That is not true. Varicose veins are part of a disease process, and that disease process is chronic venous insufficiency. These spider veins can be part of that process, but anatomically, they're two different things. The second question, varicose veins only affect women and are cosmetic only. It's absolutely false. That's why everybody's here. Varicose veins can cause symptoms, and the symptoms can be severe in certain patients. Swelling and pain, or sometimes some of the least consequential symptoms. I've seen patients, obviously, in my practice with ulcers and pretty severe disease. It's important to note that varicose veins are very genetic, and they do run in the family, so you'll see that running in the family, and they're not gender specific. Men and women can both suffer from varicose veins. So this is a busy slide. It's got a lot of info kind of packed into one page, but this is talking about prevalence. How common are varicose veins? They estimate that more than 30 million Americans have varicose veins in some form, some degree of severity. And again, this is part of the continuum called chronic venous insufficiency. There are very few, less than 10% even seek treatment. If you look at these circles, again, meant to represent how many people have the symptoms and the varicose veins and don't get treated, it's right there in the yellow. You know, we treat that many at least seek treatment or counseling, and this many go undiagnosed on an annual basis. So pretty prevalent, pretty common. We've reviewed this a little, risk factors. Again, I kind of listed these in my opinion, in terms of importance. I think age is the biggest risk factor, and that's something that none of us can avoid. Every day goes by, we get a day older, and that's not our fault. But age is just going to be one of those things we can't turn back the clock. As we age, the veins will change. They'll become more dilated. The valves inside those veins won't work the way they're supposed to, and that can cause pressure. Pressure inside those veins leads to the varicose veins. Family history, I've mentioned before, is a big risk factor. And this is the only time gender really plays a role. Obviously, having a pregnancy is a gender-related problem, or good problem. Women who've had pregnancies can have varicose veins develop as a result of the pressure that occurred during their pregnancy. Now, you might not see those varicose veins until many, many years, but that can be related. Anyone who stands at work, standing occupations, people who are overweight or even mildly obese can have an increased risk of developing varicose veins. And I think something that I like to talk about at the office is the previous surgery, people who've had injuries. It could be injuries that occurred when you were much younger. If you had a broken leg, previous surgery to fix a bone or to fix a knee, that can result in worsening of varicose veins. So some of the risk factors. 'Tis the season. This gentleman here has a lot of risk factors, doesn't he? I mean, I don't want to be too harsh, you know, because I don't want to get coal in my stocking, but he's a little bit overweight. He's carrying a very heavy load, and that's occupational. And he's constantly standing, and he travels a lot. So poor Santa Claus would be have multiple risk factors for varicose veins. So again, we're getting into symptoms. I think when I talk to people in the office, I really like to sort of focus in on what are your symptoms, what brings you in today. That's sort of one of my first questions. Heaviness of the legs, or what people call leg fatigue. That's very common. Swelling, yeah, you'll see that, especially around the ankles, or when you wear your socks. Does the elastic band of your sock leave a deep imprint or impression? That would be part of that. The feeling of restless legs at night, and I don't want to confuse that with restless leg syndrome. Restless leg syndrome is a different entity, but a lot of my patients say, you know, Doc, I have this feeling at the end of a long day that my legs are restless, and I think in part that can be due to the presence of swollen varicosities. Itching or burning, especially in the skin that's overlying the varicose veins. Ankle pain or leg pain, anywhere really you have a varicose vein, it can be painful. Aching or cramping. It gets worse when you get the changes to the skin such as redness, blistering, bronzing. The worst case scenario, you get an ulcer. And that's where the skin's actually broken open. Those can bleed and be very severe. So this picture doesn't translate as good as it did on my laptop computer, and I apologize for that. But this is just meant to be a demonstration. Everybody knows what varicose veins can look like, and that's a pretty severe case. A skinny patient, so he does not have the risk factor of obesity, but that patient does have a large amount of swollen veins. This is meant to show bronzing of the skin, and it doesn't, again, translate as well as I wish it did, but you can kind of get the drift from that. Bronzing of the skin is a problem. The veins deposit a product in the blood called hemosiderin, and that actually stains the tissue. And that's what you see when you see bronzing, and that is, again, another late finding in the process of varicose veins or venous insufficiency. So we're going to talk a little about causes. Excuse me, varicose veins, or I should say all veins, not just the varicose ones, have these little tiny valves. And this is a normal picture of what a healthy vein valve looks like. As you see here by the direction of the arrow, the blood is going up the leg, which is the purpose of your veins. Blood is supposed to travel up the leg back to the heart, where it gets reoxygenated and recirculated. And when we're standing up like this, we're creating a lot of pressure down in those legs. The blood has a tendency to pool. That's due to the forces of nature or gravity. These little tiny microscopic valves are what prevent that pooling. These valves prevent the blood from kind of sliding down in the wrong direction. But again, life's not fair when we get older. And of course, the other risk factors apply. Those valves, they just don't kind of meet in the middle anymore. They're not the way they were when you were born or when you were very young. And when this process occurs, as the arrow suggests, blood can go up, but it also goes down. And that is where the pressure comes in. When we document this, when we actually can document this, we call this venous insufficiency. It means the veins aren't sufficient anymore. And that's, in essence, what our ultrasound techniques are meant to look for. So again, standing is a risk factor, but often unavoidable. So enlarged veins, this is the definition. Enlarged and dilated veins of the lower extremities. That's the definition of varicose veins. They could be different colors, blue, red, or none of the above. They might just be flesh colored. They're often raised. People describe them as twisted or bulging, cord-like. That's a common one. I like this key point. I made it stand out. You know, there's more than one layer of veins in your leg. We all have layers of veins we can't see. We'll never see. They're called deep veins. And the deep veins inside our legs are within our muscles. Those muscular veins generally don't cause us any trouble because they're protected by the muscular tissues. That helps to, of course, fight against the forces of nature and gravity that want to pull that blood back to the ground. Our muscles support our deep veins. Deep veins are connected to the superficial veins. Superficial veins are where we derive our varicosities. So when we do venous analysis or consultation, we look at the superficial veins. We look to see how they're connected to the deep veins, and then we can see that on ultrasound often. So interconnections are important, and that's something that's part of the consultation process. Deep, superficial, and perforating veins, which are the ones that connect the two, are part of this discussion. This is meant to show that in some small way. Again, I apologize for the picture. It's kind of hard to see from the back, I'm sure. But they're kind of showing here there's a small saphenous vein, which is part of the superficial system, running in the calf. And then the other superficial vein is the greater saphenous vein, and that runs from your groin down to your ankle. And they are connected to the deep vein, which is the femoral vein. The femoral vein is not treatable, but important. And the interconnections between the femoral vein and its superficial counterparts are also important. So how do we evaluate patients? First and foremost, we see them in the office. We take a medical history. We want to know about your history, your work history, any previous surgery, any previous blood clots that have formed. Any previous surgery would be important for me to know. I want to hear from you, your story. What are your symptoms? What kind of symptoms bring you in? And then we'll examine your legs, specifically looking at those areas I've highlighted on the previous slide. Just as important, though, as my eyes and ears are going to be the ultrasounds. And we have a highly sensitive ultrasound, and that's what Brittany's here to sort of represent. Brittany is an ultrasound technician that works closely with Lakeshore Health Partners. And one of the jobs that she's tasked to do is evaluate patients for venous abnormalities. Now, Brittany, of course, does ultrasounds of other parts of the body. She doesn't just do the legs, but doing the leg evaluation is part of the job. So we look at the deep system, the superficial system, any possible connections or perforating veins. We look for veins that are not competent, which is incompetent. We look for incompetence within those veins. We're looking for those valves to no longer be normal. And if we can document that, we can make note of it. And that helps us create kind of a map, a road map, if you will, of areas we should treat. This is a very basic picture of what a ultrasound looks like. Brittany, pretty close to what yours looks like, at least at the Lakeshore Health Partners office. That's not Brittany. I should have taken a picture of you doing an ultrasound. I realized that after I started working on these slides. But I borrowed that one from the internet. That's part of it. Part of it is the patient's lying down, the leg's fully exposed. There's an ultrasound gel on the leg, and the technician is doing her assessment. And then the other part of this evaluation will be with the patient standing up. Standing up much the way I am. The leg might be up on a stool, or the patient may even be up on a stool if they're able to. And that allows the technician to examine the patient in 2 different degrees, when they're lying flat and when they're standing upright. And that's helpful. That's helpful, and that gives us different assessments. So This isn't going to be the traditional ultrasound that you may have had in the past. This is what I call a participatory ultrasound, which means that you got to get up and Brittany's in a stand and she's going to squeeze your legs a little bit and assess those segments, and that's part of the evaluation. So we talk about treatment options. So it's really important that we understand the patient's symptoms, do an evaluation, complete an ultrasound before we really hone in on what is the treatment best for the patient. There's really a couple options, right? If the ultrasound's abnormal, we can talk about what surgical treatments may be available. If not, it's not all lost. Coming to see me often will result in us discussing some more conservative options. And these options may include things like compression stockings, for instance. And sometimes for people, that's all they need. You know, if they have a normal ultrasound and mild symptoms, compression stockings may be the best option. And if not, we can talk surgery. So I just highlighted a little bit about conservative treatment. Conservative treatment, again, focuses on exercises that can help the legs, elevating, getting the legs up, especially after the end of a long day. That can help a lot with swelling. We talk a little bit here about the stockings, and compression stockings are very difficult to put on, I'll agree. And they're tight, and they're supposed to be, because what they're doing is they're putting external pressure on the legs to prevent blood from pooling. Some folks, folks with arthritis and various conditions can't put them on. But, there's an old saying from one of my mentors in training, the best pair of compression stockings is the one your patients will wear. So I have a relatively liberal attitude when it comes to stockings, and I understand people's different various stages of life where sometimes stockings are really quite difficult to wear. So that's something we can talk about in the office. Unaboot is a more advanced form of compression. It's applied either at, in a wound clinic or in a physician's office, and it's really meant for people with venous ulcerations and pretty severe disease. And again, I just listed it to be thorough, but it's very uncommon to need that type of therapy. So again, the point I wanted to make is despite all these conservative options, many of these things only help manage symptoms. That is to say, if you present and tell me, my legs hurt, they're swollen, I don't really have any bad varicosities, but I have swelling from time to time. We might start with a conservative thing, measure like stockings, to see if that helps with the symptoms. But all of these things at the end of the day, once you take them off or once you stop elevating, people will see recurrences and they'll have their symptoms come back again. And that's because we're not talking about treating the underlying cause. The only way to really get at the underlying cause is to proceed with surgical intervention, which we'll be talking about tonight. So this is a few words about stockings. Again, I think it can't be overemphasized. Any good surgeon will tell you that compression stockings are a cornerstone of the therapy. You can pick them up anywhere. Like I said, I'm liberal-minded. The best place is the medical supply stores, places such as CareLink or Airway Oxygen. But, I've been told by patients that department stores and local pharmacies carry compression stockings. They may not be what we call medical grade, but if you wear them and they help, they're good enough for me, and they're probably good enough for you. So we can talk about that. The medical grade stockings, the ones you get from CareLink or Airway Oxygen, are going to be fitted and I call it tailored to fit. The size, the shape, and then the cost too. And cost can be significant. Some people may or may not have an insurance benefit that covers stockings, and we can help you decide or figure out if you do. So I like to tell people about the pressures. The stockings come with a measurement on them. 15 to 20 is the first measurement. It's considered the light pressure. The moderate step up is 20 to 30, and then of course 30 to 40 would be for severe disease. When patients see me, I recommend either 15 or 20 or 20 to 30 based on the severity of their symptoms. So, stockings work. I support the notion. They're not a replacement for surgery, but they're an adjunct. And in the 21st century, we have to realize that sometimes there are a requirement. The surgical procedures will not be authorized or approved by the insurance companies unless the patients are willing to wear and have worn compression stockings. So that's all part of my initial consultation is discussing stockings. And here, just a very basic representation of how the stockings are supplied. And that company, again, is a brand that I've had good patients and have had good experiences with, and we recommend. All right, we're going to switch gears. We're going to talk about surgery. I am a surgeon, after all, right? So what are our options? Well, surgical options I divide out into office-based and operating room-based. And I put in red the one that can be done in both. So depending on, again, severity, symptoms, and testing, we will sort of divide people up into patients who benefit from non-surgical sclerotherapy. Sclerotherapy is a procedure where we inject veins with medicines that cause the veins to go away or collapse. This is best for small veins. And testing in the office helps determine your candidacy for this. And then the endovenous ablation procedure, which is mentioned in both columns, because it can be performed either in the office setting or in the operating room. Lastly, which has kind of fallen out of favor, especially in the last decade, would be the process of venous stripping. Everybody has a different definition of venous or vein stripping and what it entails. I think that a surgeon thinks of it in more of a kind of a whole leg thing. We think of, when I have a patient who says, yeah, doc, I've had venous stripping before, I think they've had the vein removed from the groin down to the knee. But in a lot of cases, patients will have had just a segment, a small piece of vein, whether it be from the front of the leg or the back of the leg. And so when we see people in the office, we'll categorize what's been done before and talk about how we could do it in going forward. But nowadays, I do very little venous stripping. In the older days, that was more common. But the endovenous techniques have taken the place of stripping for good reason, because they're easier for patients to tolerate, less painful, and frankly, probably more effective. So again, a few words. Sclerotherapy, office-based. Usually we recommend this for patients without venous insufficiency. That is to say, they do not have it. That's again based on ultrasound. It's good for smaller veins, and it's often covered by insurance, but we have to plan it appropriately. We have to make sure we document and discuss this appropriately. All right, we're getting into the heart of the matter. Endovenous ablation. It's called a thermal ablation, which means heat-based. Excuse me. There's different ways to generate that heat. We can use a laser energy, or we can use radio frequency energy. My training, my residency, till now, I've only ever used the radio frequency device. It's been the one that I found to be most reliable and most predictable. The laser is available, and some surgeons use it. They choose to use it based on their experiences, but I find that to be less reliable, and it's not something I use in my practice. So what veins do we treat? Again, the endovenous techniques can be used within the greater saphenous vein and the small saphenous vein of the leg. This can be done in the office without sedation or in the operating room with sedation. Whether you're sedated or not, we will always use local anesthetic. So if a patient wishes to be put under and not to be aware or awake during the procedure, we'll do it in the operating room. And if they don't mind being awake, we can do it in the office and we'll just numb up the leg prior to doing this procedure. So you can be awake and we'll talk about things like the weather or sports or various things, but it's nice to have the patients involved. So this is what the generator looks like. It's produced by the company Covidian, and it's a small little device, not much bigger than a microwave. This actually doesn't really represent the size, I think, but the devices that we use plug into this. This is a computer-generated device, or excuse me, a computer-generated treatment. So once we've connected the device that's within the patient to the modulator can evaluate the temperature and the amount of energy that we need to provide to that vein to perform that treatment. And I like the predictability of that. Again, a small cartoon to represent the stages of treatment. We place a one-time use disposable catheter into the vein. I place this in the vein with ultrasound guidance, thanks to Brittany. Brittany's actually also one of my surgical assistants. Once I place the catheter in the correct location, which is confirmed by ultrasound, we apply the heat or the energy. And once we start the energy process, we slowly withdraw the catheter. Basically, if you allow me to point it myself, we start down low, advance the catheter up the leg, and then slowly remove it as we treat. So we withdraw it slowly. And as we withdraw that catheter, the vein, because of the heat, collapses in behind it. And that's the ablation. And I have a video to show this in more detail. So again, another pictorial representation of how we do it. CVI is an abbreviation for chronic venous insufficiency. So this is a minimally invasive treatment. We make one incision, just one, and we can treat that whole vein, which is up to, in some patients, 1 meter long, more than 3 feet. Once we have the catheter in place and it's activated, as you can see, as it's represented here, it causes the vein wall to collapse in on itself. And in essence, this has taken the place of going in surgically, cutting that open and removing it. There were downsides to the cut and remove technique. A lot more bruising, a lot more pain, and frankly, it took patients a long time to heal. When we do it this way, the healing time is much, much less. So again, they're kind of showing you here how we introduce this treatment device through a sheath and into the vein of the leg. And again, I think the video will explain it better. So I get a minute to stop talking. Whew. Let's play the video.
Venefit targeted endovenous therapy delivered by the Covidian closure-fast radiofrequency catheter is a minimally invasive treatment for chronic venous insufficiency, or CVI, that can be performed in a clinic or hospital setting. CVI is a progressive medical condition where the valves that carry blood to the heart and the calf muscle no longer function effectively, causing blood to accumulate in the legs and the veins to swell. Under ultrasound guidance, the vein is accessed using standard endovascular technique by inserting a 7 French sheath into the vessel. The closure-fast catheter is inserted into the vein and advanced up to the saphenofemoral junction, or the SFJ, and positioned 2 centimeters from the SFJ. Again, under ultrasound guidance, perivenous tumescent anesthesia, or saline, is then delivered to the saphenous compartment surrounding the vein segment to be treated. This is done to enhance patient comfort, provide a heat sink to protect surrounding tissue, and to improve contact between the vein wall and the catheter during treatment. The catheter tip position is confirmed and adjusted as needed to ensure the tip is 2 centimeters from SFJ. Once in place, infiltration of the junction can proceed. External compression is applied to ensure good contact between the catheter and the vein wall. The Venefit procedure uses a segmental ablation technique, which heats a full 7 centimeter vein length in one 20-second interval. Doctors also have the option of treating shorter refluxing vein lengths with the closure-fast 3 centimeter catheter, which heats the vein in 3 centimeter segments. Working together with the closure RFG generator, the catheter is designed to deliver controlled, consistent heat to each segment. After each segment is treated, unique shaft markings on the catheter aid proper repositioning to the next segment. The heat provided by the catheter shrinks and denatures the collagen and smooth muscle, resulting in the collapse of the target vein, creating a fibrotic seal and occluding the vessel. Blood flow is naturally redirected to healthy veins as the recovery process begins. The speed and precision of the Venefit procedure offers patients a rapid and mild recovery, while providing doctors with a controlled and repeatable treatment experience.
So they used a couple terms there, a little bit of the medical lingo about abbreviations about things, but in general I liked that video simply because it shows sort of the process by which the catheter is introduced and how it functions to do the ablation. There are a couple different catheters, is one of the things they alluded to. The other thing that video reminds me is again that, positioning of the patient depends on what vein we're treating. If we're doing the saphenous, the greater saphenous vein, we can have people lying just normally out flat on their back with their leg extended. If we're going to treat the small saphenous vein, that's on the back of the calf, we have to have people actually laying over on their belly. And if they can't do that, oftentimes up on their side. So they don't talk in the detail about positioning, but sometimes that changes depending on which vein is our target for treatment. I'll just continue on with a few more slides, and then we'll have plenty of time to go over questions and things of this nature. So typically, within just a few days, a few is very subjective, anywhere from 3 to 5. I'd say most patients within a week are pain-free. My instructions after surgery basically state you can get up and walk and do most things with one prerequisite, that you wear your compression stockings. After surgery, compression stockings are a requirement, and it really helps with the recovery process. So patients who undergo the procedure will be asked to wear compression stockings. Whether we do this with you sedated or awake, it'll be done in the outpatient arena, which means you come in and go home the same day. Local anesthetic is always provided. And again, for most patients, insurance coverage is provided as long as we, again, document correctly and do the process which we in our office call predetermination. And predetermination, again, factors into a couple factors. As the patient worn compression stockings? Have they had an ultrasound, and what are their symptoms? And again, insurance companies have started to pay more attention to this procedure, rightfully so, because not everybody is a candidate. So I think it's appropriate to, play by the rules when it comes to this, and we certainly do that at our office. So here we are, 3 to 5 days is the average recovery time. I'd say the number one complaint is minor swelling and bruising in the treatment area. So the vein we treated will be a little bit sore and a little bit bruised. We only will treat one vein, really, I should have wrote vein, not leg, at a time. And there's reasons for this, and again, it's minimization of risk and prevention of post-op complications. But if, for instance, both of your saphenous veins were to be treated or need to be treated, we would only do one leg at a time, and we would ask that the patient return 2 weeks or more later for treatment to the other leg. Before surgery, it's nice if you wear stockings. After surgery, I actually kind of require it. Wearing of compression stockings improves healing, but also reduces risk factors, such as potential for blood clots forming, infections, and things of this nature. When we do these procedures, because of the risks inherent to the procedure, blood clots being the most severe, it's not the most common risk, not in any way. But forming a dangerous or deep blood clot, that is to say a clot within the deep veins, runs on order of approximately 1 in 200 patients. To minimize that risk, we wear stockings. But because it's hard to distinguish patients who have blood clots from those who don't, the current recommendation is to perform a post-surgical ultrasound on all patients who've undergone treatment. And that is a standard that comes down from the very top, from the organizations of venous surgery that make these recommendations. Again, the symptoms of a blood clot in your leg is going to be pain and swelling. Well, if you just had leg surgery or vein surgery, how do we know? How do we differentiate those with clot from those without? So we screen everybody post-surgically with a quick ultrasound to rule out any dangerous clots. Side effects and risks go hand in hand. Bruising and swelling is more of a side effect. Infection rates are very low. In the region we treat, some patients will complain of numbness or tingling, especially in the skin overlying the vein. That typically goes away if it does occur, but the rates of that are low, approximately 1 in 100. This is always one that I like to sort of focus on. Failure to improve varicose veins. Well, we go back to why we're doing this. Are we doing it because of how they look or how they feel? And if we're doing it because of how they feel, my legs ache, my legs are tired, my legs hurt, there's a very, very high rate of success in patients, subjectively. If we're doing it for how they look, the ablation procedure isn't always going to be the most cosmetically appropriate procedure, but it will be the most functionally appropriate procedure. So failure to improve goes along with recurrence. That is to say, can the veins come back again? Like your question in the back, sir, you know? I had my veins stripped in the past and now I have recurrence. And if that's the case, I can't tell you that doesn't happen, because it does. Veins find a new way. The blood finds a new way to flow, and veins can recur. And again, we deal with those on a case-by-case basis. And I told you about that rare 1 in 200, but dangerous risk of forming a deep vein blood clot. I think we're getting close. So here's a nice little cartoon. Oh boy, what's going on? Doctor scratching his chin. Does this really apply to me? What are the next steps? You know, the good news with this operation is there's really no wrong answers. How we proceed, whether we treat, whether we don't, we're not talking, thankfully, about cancer. We're talking about varicose veins. So we have a lot of right answers and very little wrong answers. What I recommend is as follows. If you have symptoms of pain and swelling, symptoms that we've talked about tonight, please, do a self-assessment. And that just means an internalization of what we talked about tonight. But don't hesitate to see me for consultation and screening. I think most people find the meeting at least informative. Education and discussion of treatment options is really what I do best. And again, not everybody will be a surgical candidate, but what I like to brag about, I guess, would be that I tailor my treatment options to what's best for the patient based on, again, their history, their ultrasound, and then their previous surgery, too, what they've had done before. So I'm kind of wrapping up. That's good. I'm on target. I told Lori 40 minutes, and I'm just about there. So thank you all for your attention. I know this is a topic we're interested in asking questions, and I'll be happy to field those next. But in terms of the video and some of the imaging I used tonight, the Covidian Corporation provided that, and I'd like to thank them as well. And there we go, the girls, those are my girls. I got 4 daughters. So don't all feel too bad for me, because they're good kids. But here we are, this is the end, folks, so let's talk about questions. Yes, sir. That is an excellent question. There's so much to say about that. I think I'll start with this. Some people actually have 2 saphenous veins, one of which is so small you can't see it. And this is called a duplication of the system. So in certain patients, that's exactly what happens, is that we close down the big one, the problematic one, and the other one gets big. But that's not the most common. The most common thing is when you close down the greater saphenous vein, which is technically within the superficial layer of the leg. The blood reroutes into the deep system. The deep system, the intramuscular highway, I call it. And that is numerous and vast, and there is plenty of extra or collateral for making up for the loss of the saphenous vein. But if I may just add a question onto your question, people always ask, well, maybe in the older days especially, my grandfather, my grandmother, my mother, my father had a heart bypass, and I think they used that vein. They took that vein out of the leg. True statement. In the olden days especially, I'm showing my age. I'm showing my age. But when heart surgery and heart bypasses were being done more commonly, let's say, they were doing saphenous vein harvesting, and they were using pieces of the saphenous vein to do the bypasses. What I understand and what the cardiac surgeons have said is they don't like to use bad veins, period. So if the vein is dilated, it's not a good vein, they're not going to use it anyway. So when I talk to patients and counsel patients about treatment and ablation, they say, well, what if I need this vein in the future? And I say, well, the ultrasound shows it's bad now in 2014. It's not going to be better in 2030, So that piggybacks on your question, but thank you. Yes, ma'am. They're independent. They are. And actually, the deep system very seldomly becomes insufficient because they're housed inside our muscles. And our muscles are housed in a layer of connective tissue called fascia. And that fascia is very strong. It's tendinous and fibrous, and it holds our legs tight. So that's what protects those veins. Think of it as your own layer of internal compression stockings, except you don't have to put them on and take them off every day. And so the tendinous fascial layer of our muscles is what keeps our deep veins competent for most or all of our lives But our superficial veins are more subject to the forces of nature like gravity.
So following up shows tests also for deep vein
Yep,
deficiency as well?
that's right. Yep, and if deep vein reflux is identified, we'll note it. There's not a lot we can do about it. That's the bad news. Good question. You know, that is very rare. And I think there's, you know, again, as a surgeon, that's not something I lose a lot of sleep over, because a vein is a low pressure entity. We're not talking about arteries. If you perforate an artery, you got blood on the ceiling. That's a bad problem. But if you perforate a vein, the bleeding is minimal, and we can control that with pressure, just simply by, you know, kind of pushing down on it for a few minutes. So perforation is rare. And when you think back to how they used to do it with the stripping, when they would make a cut or a couple cuts and then give it a good old pull, there was a lot of perforations and a lot of bleeding. So it's apples and oranges when you kind of compare how patients look and feel after surgery. The post-operative vein stripping patient had a lot more problems than my ablation patients do. Good question. You know, I go to meetings myself. I just recently went to one, and the lecturers often state, if there aren't any questions, I either did a really good job or nobody was listening. You know. So yes, ma'am, in the back. You know, I think it depends a little bit on, again, the risk factors to begin with, because there's some things we can't change. And heredity, and I guess you might call that family history, is hard to fix. When we categorize recurrence, I like to say, again, is it recurrence of how they look or how they feel? Patients who have venous ablation will feel better 95% of the time. In 10 years, Covidian did a study, and they found roughly 10% of those people had functional recurrences, which meant they were back to where they were from a symptomatic standpoint. Cosmetically, how they look, those patients have about a 60 to 70% approval. And at 10 years, you can see 20 to 30% of those patients have a relapse cosmetically, which is to say that little blue vein on the outside of my leg showed up again, but it doesn't hurt. So I like to break people into two categories when we talk about recurrences. Is it a functional recurrence, that is to say life-altering or debilitating, versus, oh, it just doesn't look good? You know, in my practice, the patients who have the little purple veins that don't cause a lot of pain or symptoms are the ones we can treat very easily in the office with sclerotherapy as an adjunct to the ablation. And that helps with that. So that's very good. Yes, sir. Right. If the deep system's good, but the superficial system's bad, what we often see is that the blood will pool back up, if you will, and that causes leakage. And what moves best through the wall of the vein is nothing but good old-fashioned water. In the human body, we call that serum, because it's body fluid. As the serum leaks out of the veins, it goes into the tissues, creating weight, heaviness. The heaviness really is the cause of the fatigue for most patients. It's like pulling around an extra few pounds. And it may not seem like a lot, but over time, vice versa.
So the cells are not being
Yeah,
impacted.
right. It's just the leakage from the superficial. Yeah. And again, the worse the varicose veins are, the worse the fatigue will be usually. There's a correlation there you see when patients. So that's good. That's a good question. The format we like to follow is 2 to 5 days. So based on Brittany's schedule, which is usually pretty available, we'll bring patients back in. In my practice as it stands now, and things can change, we typically do these vein procedures on Tuesdays and Fridays, and then the patients who are treated on Friday surgically get their post-op ultrasound on Tuesday, and vice versa for the other day. So that's about a 3-day hiatus, and that's enough time to allow us to assess for any post-operative complication. Patients who get the blood clots will usually get them right away because it's a heat-induced process. The heat from the catheter, although meant to be in just that superficial vein, can dissipate at times or cause an inflammatory response. And that inflammatory response can cause blood clots to form in the legs. We've all heard, if you watch too much TV, you'll hear about blood clots all the time. And we all know various surgical procedures can precipitate blood clots. People can have open heart surgery and get blood clots in their legs, and they're separated by, geographic differences, but it's the body's immune response to the initial reaction of the surgery that can cause the clot too. So we typically check within 2 to 5 days. Great question. I mean, it really depends on, well, the driving thing is interesting. The people who come to my office to have this done and are fully awake, they don't take any Valium, and they're interested in having this done with just local anesthetic can drive home if it's their left leg. If it's the right leg, I think because of the numbing, I'm always worried about a little bit of delayed reaction to the pedal foot. I ask that you have a driver. Driving after surgery, though, isn't restricted once the numbing is worn off. You can drive usually within 24 hours. As far as your other question was time off of work, it depends on your work. Heavy lifting is the one thing I ask, and I don't require, but I ask that you try to avoid usually 20 to 40 pounds. If you have a job where you stand on your feet, you should wear your stockings. You should wear your stockings regardless. As long as you have your stockings on, you can actually do light exercise. I encourage you to be active at least 30 minutes 3 times a day, starting on postoperative day 0, which is immediately after. So work isn't usually restricted for much more than a day or 2, depending on your type of work. It's using a medicine in a small needle. Actually, the needle is no bigger than a needle we might use in a diabetic or a patient who has diabetes might inject insulin with. But we take this very small needle and this medicine together, place it into the varicose vein, and inject. And what we're accomplishing is putting in a medicine that's really quite bad for that vein on a very, very localized basis. Now, obviously, if we put a whole boatload into you, it would go around and your circulation would be bad for you in general. But we use just a small amount. And by injecting it, we can hold pressure and get that vein to collapse in on itself. That medicine creates a sclerosing effect, which is an inflammatory response that causes the vein to close in on itself. But just like the ablation catheter here, we have to wear compression stockings for about 2 weeks after sclerotherapy to help with the healing process. Yes? It's called a sclera. A-S-C-L-E-R-A, a sclera, and it's made, that's its brand name. The trade name is polydocanol, and it's made specifically for the process of sclerosing veins. It's FDA approved for that only. In the older days, again, not to date myself or age myself here, they used hypertonic saline, which meant concentrated salt water, 24% normal saline. And in my more modern training, it's been recommended not to use that. Yep. And in most patients, we can. Case by case, sometimes we run into difficulty. We may have to access the vein twice. We like to just do it once down low. But if we can't, sometimes we have to access it here, and it depends on the patient. But generally speaking, it's one access, one entry. You're going to be on the table about 45 minutes. Whether we do it in the office or the operating room, it's the same procedure either way. It really comes down to the patient's expectations and experience. I'll use the word needle phobia, and I think that everybody knows what that means. And if a patient walks in and tells me straightforward, I have a needle, or an aversion to needles or to blood, I would recommend they be sedated. When I counsel patients on this, I typically state 75% of patients can be treated in the office setting, and 25% are often treated in the operating room under sedation, which is one of the unique things about my practice. When I was in my training, we only did these in the office, and I have to say I saw some patients who didn't tolerate it very well, and it was the minority. But when I was young and training and becoming a surgeon, I thought to myself, when it's my turn, I'm going to make sure I can offer it both ways. So it's a customer service thing, really. We just use lidocaine. 1% with a little bit of epinephrine in it as well. Yeah, that's it. And back to you, sir. No, because it's superficial veins, and because it's so superficial, it's basically expendable. So we can live without it. The body doesn't miss it to that degree. Back to your question, to be a little more clear about the local anesthetics, we mix that with half of a liter of IV fluid. So what we're really giving you is diluted lidocaine. Because again, I think we've all had lidocaine injections. I know I have, and they burn a lot. And this, because it's diluted, burns less. It also gives us this ability to kind of flood that fluid around that vein, like they showed you in the video, how I inject it and like to kind of cover, get a nice little covering around that vein. The fluid really does two things. It compresses the vein, but it also protects surrounding tissue. You know, if we had a little tiny skin nerve that was kind of jetting along here, and it's not a nerve that's going to cause any functional problems, but it could just be sensation. That little nerve could be subject to injury. So by placing that fluid, we minimize the chances that we would cause thermal or heat-related damage. So, good question. Yes, ma'am? No, not in general. I like to, right, well, I mean, let's be honest. So I think in the office, we discuss that, you know, pretty well, case by case, you know, and what it is that the patients truly need out of the procedure, I think is the right answer. I mean, why we're doing it is more important than can we do it in certain age groups, yes. First and foremost, the symptoms help me to decide which candidate. Every once in a while, I see somebody with very mild symptoms, and in talking to them and understanding what their expectations and desires are, I realize this isn't somebody who probably even needs an ultrasound. This is somebody where you can just simply do sclerotherapy, which is an office treatment, and we leave it at that. But most of the time, the patients come, and they have a multitude of symptoms that makes me wonder, do they have venous insufficiency? And then I order an ultrasound, and we move the process forward. And you know, to speak to that too, depending on your primary care doctor or which office you go to, some primary care doctors have had basically the same presentation given and in their offices with me, and they will order the ultrasound. The one that I need, the duplex ultrasound that I've referred to numerous times, can be ordered by your primary care doctor depending on who they are and which office they're out of. And that does save, in certain patients, save a step, if you get what I'm saying with that. So if you have bad varicosities, pretty good story for having bad symptoms. You go to your doctor, your family doctor. They can say, okay, I'm going to send you to Dr. Dishinger, and I'm going to order you an ultrasound. And that does kind of speed along the process. But, you know, primary care doctors have told me, you know, sometimes we're not comfortable. We don't know who should and who shouldn't be tested, and they'll send them to me for that decision-making discussion. So.
Do we need a referral?
Not in general, right, Lori? Right? I don't think so. Yes, no, well, I was going to say, welcome to my world. No, yeah, you're right. If it was all a cartoon, it would be so easy. The veins aren't straight. And even the one that, you know, we've spent a lot of time talking about, the saphenous, the greater saphenous vein, in a lot of patients isn't straight. So we do our best to, you know, get the catheter to go through. And there are some, you know, tricks of the trade to get the catheters up there. We have small wires and things that can, if the wire goes through, the catheter follows, things like that. Ways that we do this. But that's an excellent question. It is challenging at times. No, not really. Not really. If your swelling isn't severe, your skin is intact, you've never had an ulcer or an infection or a blood clot, then no, you're probably okay to go on like this. And maybe what I would recommend would just be compression stockings. You know, ones that are easy enough for you to put on too. You know, they don't have to be the world's tightest to be effective. So.
Would it be all right to wear the lighter ones?
Yes, absolutely, absolutely. Good questions.
Thank you.
Yeah, you're welcome. All right, I think we did a lot of talking. I did a lot of talking, but we did a lot of information dispersion tonight. Any other questions before we wrap up? I really want to say thank you again. On your way out, you know, if you'd like to meet with me personally, we're going to do some vein screening in the office, which we're not going to have a charge for, and that would be a good way to start this conversation on a private level. And from there, we'll talk about whether we need ultrasound and things of this nature, and then Brittany and Lori can help you sign up for that, or just take my card if you're interested in talking more. Thanks, everybody. Thanks a lot. Yep.